In the case you have forgotten me, it's about the same guy, just about 20 minutes older than it was before. You are so fantastic audience that I would love to talk forever here. So my talk with challenging case is also interactive. It's going to last about 2 to 3 hours, so I think that won't be any problem about it. Yes, again and again. Now I'm trying to make it shorter, although you will have the even chances. I warn you, it was the patient with a history of genital warts, and he came to be seen by me in order to apply the treatment. Well, something was not in the way I wish. And then again, now only clinically, this has been lasting for about 2 months. Now again, please. We'll have enough time, don't worry. If necessary, I will dance on the table to finish on time. So it's not a problem. Because, for example, you are fantastic. I would be never able personally to download so quickly. I'm already horrible in that. So I admire you and I envy you for your technical skills. Now, can we move? Thank you. Now, what's your diagnosis? I'm telling you, it's about 2 to 3 months, the history of recalcitrant genital warts. And something, well, I have to wait. Now, I learned the lesson from the last time, so we give you. Now, what's happening? Okay. Yes. See, look, it doesn't look so typical. And the patient has a history of recalcitrant genital warts. It could have been perianal as well. Well, you know, we have to pay attention. They are more confluent. They are a little bit moisty, which cannot be seen on this photo. But they are not like from the textbook. Anyway, even if, because you know, the older dermatologists, they only thought about condyloma lata. The younger ones forgot about it. So if we are not sure, let's make syphilis serology, because the treatment is completely different. I mean, this patient, you put it cryotherapy, podophyllin, and so on. And then again, please remember, this kind of syphilis 2 infection is rather contagious. And by histology, as my dear colleague for oral lesions has said, there is a plenty of plasma cells. So this shouldn't be histologically a great situation. And then again, it can be mixed. The patient might have recalcitrant genital warts, but this should be treated. So as I told, a great imitator. And, well, you know, the treatment, maybe in Emirates you are in better situation because, as you know, there is a horrible shortage of extensilin in most of the European countries. Now its situation is a bit better, but for some reasons, benzathine, penicillin, extensilin was in a kind of shortage. We have reported that problem. The situation has been better. Well, this is not that easy. Well, it can be. It can be either of those. So what's your diagnosis? Well, let's see. You are right. You are very right. But it could be anything of that. Now, let's see some of the, because, you know, challenging cases, there are many. Each of us has a lot. The things that we really come across with, that the patients, even that they don't confess they have administered anything. So please, whenever we have something very, you know, unusual on the genital region, first think of the irritant dermatitis. Okay, it shouldn't necessarily be, but the people put anything there. For example, this was some homeopathic preparation, quite often. What should be ruled out here? Herpes, excellent, excellent, herpes. Well, it's not always easy. It's not always easy because less and less we see syphilis with a primary stadium. It's either missing or it's not registered by the patient. It's not typical anymore. So it's not anymore always a situation with a typical primary lesion and so on. And then, of course, it shouldn't necessarily be on the genitalia. It can be in oral cavity. It can be anywhere on the body. This is sometimes it's not always like that. This is quite typical. And there are also oral lesions with this. Well, that's, sometimes we have to understand that to the certain part of irritation, using any topical chemical treatment for genital warts, it's not the end of the world. It's important thing, in my opinion, to warn the patient. Please wash it out if it is podophyllin or if it is something else, and be prepared to have some erythema or something unpleasant. We should warn the patient. Otherwise, they come in emergency, oh my God, what happened? Not a miracle happened. It wouldn't go away by itself. So we have just to warn them. Okay. Now, I think we have a possibility to vote. I mean, you are such experts that this is easy for you. Obviously, your team of Professor Ahmad and Professor Pramar, they have taught you wonderfully. Well. Don't we have the answer in? No. Anyway, your answer was correct, by the way. Maybe I forgot to put this. Now, thank you for that. We spoke a little bit about gonorrhea last year, and let it be in suspense. You'll hear about it on the Used to Europe conference in Zagreb, so let's leave it something like Hitchcock in suspense. Then again, we haven't buried podophyllin in Croatia. In most European countries, it has been put away because it is not always the same concentration and so on and so on. That's true. However, if in the hands of the skilled doctor, and if the patient follows the rules, it should be washed out in 3 to 5 hours and so on, it's not that bad. And sometimes we combine, we make cryotherapy first, and then we put podophyllin. But it's important to warn the patient. The patients, as podophyllin is not painful, they don't wash out, and then these things happen. I think that to each of you this has happened. It's not the end of the world. Sometimes inflammatory reaction following podophyllin treatment might be so severe that the patient requires steroid oral treatment. But even so, this is not the end of the world. And my friendly advice, if there is any podophyllin in Dubai, I don't know, don't give it to the patient for the home application. Podophylotoxin, yes. Podophyllin, no. Anyway, there are many irritants and many allergens, so it is quite common, and think of this first. But of course, there are many potential reasons. This is some of the contact dermatitis. Well, especially vinegar or onion, the patient would put anything because they think this might cure. You know that even for the warts, for the common warts on the hands, the so-called home remedy was a kind of onion or something like that. We cannot avoid it. That's reality. And now something, I refer to that. We had this patient, by the way, verrucous cancer is the situation where two pathologists wouldn't agree what it really was. It is either squamous cell cancer, which is dangerous. Verrucous cancer is something in between. This is important to be a very proudly dermatovenerologist, because here the oral surgeon has advised ablative surgical procedure. It would somehow damage the lip of the patient. If it were squamous cell cancer, we wouldn't be in doubt. Verrucous cancer is a very loose pathophysiological diagnosis. And then my colleague, Professor Ljubojevic, who is the co-president of the conference in Zagreb, and me have decided not to listen to the surgeon and to start our combined treatment, ablative and imiquimod. If that wouldn't have worked, then we would have referred the patient to the surgeon back. And look, after about 2.5 months, it went out completely, with no recurrence. It's not always like that. But sometimes believe to yourself. Be proudly dermatovenerologists. That's what I want to say. Okay, I'm telling you, if it was squamous cell cancer, we would have thought differently. This was a very impressive case, very, very, very impressive case. And well, look, I don't mind surgery here, but you can imagine the extension of this wound if this would have been taken by surgery. So, but I'm not sure if I would do that again because I'm not that young and crazy as I used to be. So, we had every second week combination of electrosurgery, cryotherapy, and so on and so on. Oh, it was quite bad. And you know, but it took it took almost a year, because at home the patient has been given imiquimod, and in our office it has been some kind of ablative treatment. But I mean, I'm not clever enough whether to recommend it or not. But that's what I recommend. Males are the part of the HPV vaccination program. Definitely. It cannot be a genderly orientated vaccine. So there are a lot of evidence today about the necessity of the male vaccination, also for the herd immunity, but not only because of that. You know, I can list you thousands of studies. This is also, it's not a treatment vaccine, but it can help the treatment. There are a lot of discussion about that. I'm just giving, it's not classically the treatment vaccine, but it can help the treatment. So today there are some other situations, some other evidence, especially about recalcitrant wart. And there are some of the agents that might help. So it is, this is interesting. In some cancers, HPV-induced, nivolumab might be a potential biological. And I say, thanks God we have some biologicals, because otherwise all biologicals will go into psoriasis, into hidradenitis, and so on and so on. But this is still in experimental phases. Well, it's not like that. Only in the cohort group, the children 12, 10, 11, they can be by 2 doses. The adults should be given 3 doses. As yet, we have our task force EADV on HPV. Please come join us. We had recently held a very successful course in Athens. So if you are EADV member, you got it for free if applied. Then, as I told you, it's for Zagreb, again. And nothing without human contact. By this, I wish to thank you to my dear friends and colleagues from Dubai. These photos are raising. There are more and more dear people on this. So the people, my dear friends from yesterday evening, will be on the next. And no robots, no virtual medicine could replace our human contacts. For that, I am most grateful. Shukran, thank you very much for your kind attention.